Hey guys, it's Tatiana. Thank you so much for being here. I did want to give you a fair warning that a few parts of this episode got choppy. There's a handful of sections, 5 to 10 second bits, where Dr. Garchar is breaking up, sounds a little bit like a robot, but good thing your brain is a predictive processing machine and is able to fill in the words. This conversation was just too good to cut, so please hang on with me. It's a fantastic episode. Let's go. Dr. Kim Garchar, welcome to Lucid Commons.
Thanks so much for having me. I am an associate professor of philosophy at Kent State. I specialize in ethics, and I'm also a clinical ethicist. And I work as a consultant for a local hospital. Um, I study death and dying.
And your cat mom.
I am a cat mom. They may or may not make appearances. So if there are funny noises, I
That's
have
what's
one
going on.
cat in particular who has a very characteristic meow, or uncharacteristic, I should say. And the dog, thankfully, is at daycare. So we will
Oh,
not be interrupted by dog.
I am curious about this work, death and dying. So,
Hmm.
in my first career as an ICU nurse, I experienced a lot of death and dying. Death and dying is one thing that we all have in common. We're all going to die,
Indeed.
right? Let's just
Exactly.
rip the band aid off. It's
Yeah.
going to happen, it's inevitable. Generalizing, as a society, we don't like to talk about death. We don't like to sit
Correct.
with our own mortality.
That's right.
Can you say more about why you were drawn to studying death and dying and what death and dying means to you?
Yeah. So I think my initial sort of pull in that direction was that I grew up with grandparents who openly talked about death, their death, their friends' deaths. Death was not a taboo subject. Indeed, sometimes it was a topic of humor. They often, as they aged, talked about their friends and described them as they're circling the drain, meaning they are declining. And that always seemed very normal to me, as most kids, kids grow up thinking whatever they experience in their family is normal. And I learned as I started studying philosophy that, in fact, that wasn't normal, and that many people don't often speak about death, and many people are uncomfortable speaking about death. And I think your experience brings to the fore the need to change that overarching kind of social tendency. Because if I recall correctly, you began your nursing career, former nursing career, during COVID, and you were an ICU nurse, correct? Right?
Mhm.
So you were dealing with an unimaginable number of deaths that were experienced in new ways in our medical system. They were often alone. Even their caregivers were in PPE. There was very little human connection there. And I think, personally, having lived through COVID, but it seems to me that we were very quick to write that picture of death and dying off, right? We were happy to keep it in the hospitals, let the healthcare providers deal with it. And as a society, we aren't even good at conceptualizing the number of people who died, right? Let alone what was leading to, or besides COVID, what was driving us towards these deaths that most people would describe as as somewhat torturous, right? Because they were lacking this human connection. So I've always in well, one, having grown up talking about death, I view death as an opportunity to think through different aspects of what it means to be human, different aspects of connection, different aspects of transition. And so I find all of those philosophical questions very interesting. And I think you lived those philosophical questions, right? And this
Mhm.
is, I don't mean to put my experience on you, but, from knowing you and knowing what your work was like, it seems like you were very much in the midst of those questions, but sadly, in the midst of it with other nurses or doctors. And that the patients weren't able to communicate, often ventilated, right? There would family weren't allowed to be present. Um, Even your family had to be isolated because you were exposed to contagious materials at the hospital. I mean, those first months of COVID must have been terrifying. And as a healthcare provider, going home and worrying about your exposure to others and being, ensuring that you were showering and taking your clothes off immediately when we really were struggling to understand the illness. So, that is a long-winded way of saying I think that death raises the really interesting philosophical questions without allowing for a caricatured answer, right?
Hmm.
That you can't simply say, "Oh, yeah, the meaning of life is to," um, trying to think of something that won't be taken incorrectly by someone, but we can't say, "Oh, the way that you create your life is to create," for example, art. I love art. I love artists. Simone de Beauvoir, de Beauvoir, in fact, says the artist is some of the highest forms of philosopher. And so I am not bashing on art, but we can't reduce it to these single things. We have to think through something far more complicated when we are starting with the understanding that we die.
In that vein, I'm thinking about oh gosh, Atul Gawande's book, Being Mortal,
Absolutely. Yep.
and talking about the medicalization of death, but also talking about how, as healthcare providers, I know there's this controversy with using the term provider right now, physicians and clinicians and nurses, we are trained in a philosophical sense, but also in a very practical sense to
Yep.
fight death.
Exactly. Exactly. Yeah,
What
so
more
it
do
very
what yeah, I'm just gonna land there, and you being a medical ethicist, to what degree should we be fighting death? It is literally the definition of our profession, to
exactly.
alleviate disease and
Yes.
to prevent, I'll qualify it, premature
Correct.
death.
Correct.
But then let's dwell on premature, right? Because we know that there's cases that are not cut and dry. I've had cases in the ICU that are just really challenging quality of life discussions, right? It's not cut and dry.
Absolutely.
So what are your thoughts on taking everything you know about philosophy and medical ethics and bringing it to maybe some of the practical moments that you have seen, in your consulting work and ethics
Yep.
work in the healthcare environment? How do those conversations play out? Like, are we meeting
Yeah.
people where they are? How do we navigate those practical discussions?
Yeah. Okay. So I love, of course, Gawande is the one of the most popular, well-known um, ethicists and clinicians out there. I mean, he practices both, and he very plainly says physicians are trained that death is the enemy, and physicians will never win a battle against death, right? And I think it's interesting that the battle metaphor has come to really dominate medical training around death. Um, that it it seems odd to cast it in terms of something you must defeat, knowing it is undefeatable. And perhaps the key, I think, is that he would clarify if we could have him here. He would say, "What I mean is, we battle premature death, as you stated, that's fair. But when it's cast as a battle, for example, cancer patients have to fight, right? Have to battle death. And even during COVID, we began importing battle metaphors and using them to describe the clinicians, the healthcare clinicians and nurses, um, other caregivers. We started using that to talk about our healthcare clinicians. Um, we talked about them being on the front lines and not having the right ammunition, meaning PPE. And they were performing as, soldiers. And it is so odd to me to use a metaphor that requires a victor, requires a winner, when you know your enemy will indeed be the victor. Why do we cast ourselves continuously as struggling against, warring against, battling against, combating something that will win? So I feel like it's more than just the medical training, which is problematic because clinicians, both nurses, physicians, respiratory therapists, everybody, their education is so intense and packed full of necessaries that when someone approaches and says, we really need to add this to a medical curriculum, the answer is always there is no room, there is no time, there is no space, and that is fair, right? We expect our clinicians to be experts in their field. However, when we have cast them as soldiers in an unending war against an enemy, it seems that perhaps we should work to understand the enemy a little bit better. And it's not that it's understanding death. I'm not sure that we can, as humans, fully grasp all of that. But we have to be able to think about it such that we are comfortable enough to speak with patients and to change a kind of national level conversation about what's actually going to happen to all of us. So, yes, I think there is an issue in medical education, but it is mirrored, or at least I will say it's magnified by the social imagery in general, because we do talk about, you know, fighting death. She was brave. She lost in the end, but she was a good fighter. All of this metaphor actually reinforces what we think we're seeing in healthcare, that we see death as an enemy to be vanquished because that's how we talk about it. That's how we picture it. That's how we expect our patients to picture it. And that's a problem. So it's bigger than just that healthcare education. It's, an issue of the way we think about it in general. And I think I will just say, as an aside, a healthier way to think about it is one of transition that we all move through. I don't I don't claim to know what's on the other side of that transition, but we know that our kind of existence changes. And that seems to me to be far more accurate biologically and comforting personally, that we can think about, I've been changing my entire life. We change from birth, and I will continue to change. I don't know what I will change into, if anything, but it doesn't make sense to me to think of it as an enemy or a foe to be vanquished.
Hmm. Yeah, I appreciate that perspective. That was one thing I learned in going through, law school and practicing law is realizing the power of words, right? Words matter. Careful, deliberate word choice matters because
Mhm,
it's reinforcing. It's telling your mind, your body
mhm,
the lived experience that you're going to have that you associate with those words and
mhm.
that reality, right?
Absolutely.
I really because that was gonna be my question, if you could change the national conversation, what would you change it to, right? And I appreciate this,
Yeah.
framing of it as a transition,
Mhm,
and having gone through several life transitions myself, like recently motherhood, career pivots, things like that,
mhm.
one thing that I've realized about myself, but I think we can say about humans, we know this in general, is we don't like change.
Correct.
We fear change, we fear
Mhm.
uncertainty, and it is
Yeah,
biologically programmed into our nervous system, like,
absolutely.
first principles to avoid
Yeah.
that, right?
Exactly, because it's dangerous or
Right.
potentially dangerous. The 2 things I think mark the human condition is we are finite and we are fallible. And beyond that, we live in an ecosystem, and ecosystems are nothing but systems of change. Our bodies are nothing but systems of change, and yet we are evolutionarily wired to resist it at all costs. And, I think in addition to simply having a willingness to talk about what might happen, what might be the case, um, and an openness to think about death as something we shouldn't maybe be fighting against. I'm, again, to make clear, I am not talking about welcoming death. I am not talking about jettisoning modern medicine. That is not my point. Um, but to think about it instead in terms of what medical decisions work for me right now, where I am, and move forward from there. But the ability to change the way we conceptualize it metaphorically. And I will just make a quick aside. There's a fabulous book by Mark Johnson called The Metaphors We Live By. And he was
Hmm.
one of my profs in grad school. And it he was one of he is one of the biggest names in terms of metaphor, um, working on metaphors and the way that they actually shape our world.
Hmm.
So I recommend him, but yes, the metaphors are important. The ability to simply vocalize, like I'm worried, I'm scared, or I'm really okay with it, or I don't understand why grandma isn't choosing aggressive treatment. I'm confused because that seems scary to me. Any kind of ability to vocalize thoughts about death will, I think, be beneficial in the long run.
Hmm.
Now, those uh, emotions are not always.
Hi, Ozzy. He's so cute. Hi. Oh, he's got beautiful eyes.
Yes, he does. So I was talking about the emotions we discuss will be hard, and I think one of the important things you said in your introduction was We don't like to talk about death. We don't like to sit with our mortality. And I have learned, and this is incredibly hard, and I'm not claiming to be good at it, but simply sitting with someone who is hurting for whatever reason and not attempting to fix, not attempting to problem solve, not attempting to move them on to a better topic, right? To remind them of all that they have good, to simply sit with anyone who is grieving, suffering, confused, that is very hard. And that too, we have overlooked in terms of social training. So it is something we need to address. I am not sure how to approach that, but
Mhm, mhm.
that's where we
Yeah,
are.
I can relate, and I can't say that's training that I got in nursing school, right? Nobody
Right.
trains you on how to have an empathetic
That's right.
conversation, how to regulate your own emotions so that you can help co-regulate someone else's nervous system, right?
Right.
That's something that you learn on the job. That's something that you might fail at, right? A couple
Mhm.
times, iterate, try something new.
Yep.
That is something that I still fall prey to, I will say sometimes, is trying to fix, right? I'm a
Yeah.
fixer. So I hear,
Me
someone's
too.
telling me a story. My husband's telling me something, a friend is telling me something, and I'm
Mhm.
immediately thinking of a million different solutions. Well, did you try this? Did you try what if we do
Mm.
this, right? And I do the
Yeah.
same with myself, like, "Oh, how can I fix it? Once
Yeah.
I know that it's a thing, how can I fix it?" And that is one thing I'm just now learning in this season of life, is how to just be, how to exist
Yeah.
in this uncomfortable feeling. And I think, again, obviously, clinicians, I think just by
Mhm.
virtue of the training and the
Mhm.
practice and fighting, right?
Mhm.
Healing. I don't like the fighting metaphor either, right? Fighting death.
Yeah.
I see us as the healers, right? I see physicians and
Mhm.
clinicians and nurses
Mhm.
as the healers of society. And I don't see healing as just alleviating disease or fighting death, right?
Mhm.
I see I see it as alleviating suffering,
That's correct. Right.
human
Not all
suffering, yeah.
suffering,
Mhm.
but some suffering.
Some suffering, yeah, yeah. Because
Yeah.
suffering, a healthy amount of suffering, right? I've been through suffering, you've been through suffering.
Yeah.
It's part of the fire that molds you into the person that you
Mhm.
are, right? We
Mhm.
can't get rid of all human suffering, but when I think of alleviating suffering in respect to death,
Mhm.
I think about just honoring,
Mhm.
like you said, sometimes, family members. That was something that I experienced. But family members
Mhm.
don't, and it's normal to be selfish, right? Especially when you see a loved one going, like, you selfishly, you don't want them to die. You don't want to. It's not only that you don't want to have this hard conversation about death, but you don't want that loved one to die. You love them, right?
Yeah.
And too often it became a conversation of what the family wanted and the family's wishes and the kids' wishes, and not
Mhm.
the mom or the dad's or the grandma's wishes, right? Not what they wanted at end of life. And that was my experience in the ICU. Is all too often I saw healthcare happening to patients, and they
Absolutely.
lose their sense of agency to physicians,
That's
clinicians, to their family. And that sense of agency, I see that as suffering, right? As
mhm.
being stripped of your sense of your voice, of your sense of agency and
Absolutely.
control over how you want to leave this world.
Yeah.
I don't have the solution to that aside from having the conversations, having the hard
Mhm.
conversations, and prompting gently in a non-judgmental way,
Mhm.
"What if we considered this? What if we
Right.
asked your loved one how they think of a peaceful
Mhm.
passing?" Sometimes light, to bring levity, a little sense of
Mhm.
humor, right? Death is something that we all have it in common. We're all gonna die, right?
Mhm.
How would you want to go? Kind of creating a sense
Right.
of empathy. And
Absolutely.
that might be a step in the right direction, but it's not the solution. I think
Yeah,
there's a long way that we have to go in our
for
society to
sure.
get a little bit more comfortable. I'm curious about different cultures. Have you explored different
Mhm.
cultures and how they view death and approach death
Um,
compared to us?
some. I'm a little hesitant to claim knowledge about different cultures. I do want to add just a bit of emphasis to exactly what you've just said, though. So, Oregon was the first state to um, make legal what at that point in time was called physician assisted suicide. Now it's medical assistance in dying or death. And they have been collecting data as is required by their law since 2000. So they have very good data on the numbers, who it is, their insurance status, their education status, because there were all of these slippery slope arguments being made that turned out to not be empirically validated. But what they did find in talking to people who chose to use the law, their number one reason for wanting to have a lethal substance in their possession for their use, should they make that decision, is agency. Their primary issue was a fear of loss of autonomy. And, their actual pain levels are reasonably well managed according to that data. Um, their issue is, I want to leave this world, transition out of this existence, um, according to my own terms. And I there are now, I think, upwards of 10 states that, allow MAID, medical assistance in death or dying, possibly 15, and I have not looked at all of the data from all of the states, but I'm very familiar with the Oregon data because it is, it has a lifespan of information there, and, um, yeah, so your point that patients who are dying often lose their voice, and even if not literally because they're intubated or sedated or all of these reasons, they lose their voice to their family members or even what their clinicians think is right. And I have found from working in ethics committees in adult care, normal hospitals, the majority of cases that we get are about differences of opinion in treatment options at the end of life, where you have a family or at least family members who are requesting more than the health care team thinks will be medically beneficial to the patient. And when you talk to the family, many times it comes down to guilt. They do not want to be responsible for making the decision that in their mind kills their loved one. And again, this is a problematic framework or conceptualizing of the issue at hand. They are not in any way um, killing their loved one. They are indeed trying to offer support often to what the patient wants. But that emotion, guilt, drives so many responses. And when you kind of drill down a little and say, well, what do you think your mom wants or dad wants or grandma wants? Well, I think she would want this. Okay. So why are you asking for something else? Well, I think she can get better and then she would change her mind. Or I think, maybe she doesn't know what she's asking for now. Maybe she doesn't understand the finality of it. And there are lots of reasons for dismissing patients' stated wishes. And I guess maybe I would like to explore this a little more. I will give one quick example of a case that I saw many, many years ago, and not even in this state. So there's no risk of confidentiality violations. But there was an elderly man. He did have a, an advanced directive. He stated very clearly in his advance directive that were he near death, he did not want any feeding tube. He did not want any aggressive treatment. And this elderly man had a stroke. He was in like an assisted living, not a nursing home, but he lived there with his wife. He was brought to the hospital. He became septic. And as you know, as a nurse, sepsis requires IV antibiotics, a long dose of them. But you also then have to nourish the patient to keep them alive long enough for the antibiotics to work. So the question was whether or not to place a feed, an NG, or actually, it was a peg, I think, a peg tube for this gentleman so that he could recover, using the or, hopefully the, antibiotics would work. And his wife, who was a second wife, said he has clearly said, "No, no way, no way," doesn't want it. His adult son hesitated, and he said, "I need I need to think about it." And this adult son, to his credit, um, practiced his religion. He was not Christian, but he prayed in his way. He consulted other um, clinicians. He researched this. And when he came back and said to the doctors, "I need you to place the feeding tube," uh, and the clinicians were like, "Why?" And he said, "Because I'm not convinced he's near death." And they said, we can't give you a time, but your father is dying. He's actively dying." Um, that case has haunted me because here was this son trying to honor his father's directives and wishes, but still could not get past his own reluctance to simply say, "This is what my dad wanted." And they indeed placed the tube, and
Mm.
I honestly don't know what became of that patient, other than I'm certain he expired within probably a few months, if nothing else.
Hmm.
So,
Guilt. That I feel like so many of our decisions can be driven by guilt, and this is one of the
absolutely.
areas where that really matters, where our decisions
Mhm.
should not be driven by guilt. It makes me think of I remember in our undergrad intro to ethics course, one of the very first lectures you had started out by asking is, posing a hypothetical. You're at the park, you're walking, you're passing the pond, and you see someone
Mhm.
drowning. They can't
Mhm.
swim, they're screaming for help. Do you have a duty to go save that person?
Mhm.
Or can you just keep walking?
Mhm.
And it was, I think, your way of presenting commission versus omission, right? Errors of commission versus omission. And that's kind of what I think of when I think of family members maybe avoiding making a
That's right.
decision
I
and
think
making the
we
call
yeah.
by choosing and the paradox there is that, okay, well, in avoiding it or choosing something that you're choosing, that's
Yeah.
commission, right? Even though you're
Absolutely.
avoiding it, which
Absolutely.
which is, is challenging, but I think it provides a sense of comfort and
Yes.
certainty, right? And talking about
Right.
how human beings, we don't biologically, we can't sit with uncertainty. So rather than going with the uncertainty or with the guilt, we choose what we do know. We do,
Mhm.
we choose a decision that we can make, that we have agency over.
Mhm.
And we'd rather choose that than
That's right.
the sensation of lifelong guilt or
Yeah.
uncertainty or what could have been.
Mhm.
And in terms of having the conversation with clinicians, with family
Mhm.
members, I'd love to hear how your experience, so as a philosopher, as a medical ethicist, and being on these ethics committees, how does theory translate to practice? Like, walk
It's a great
for people
question.
who don't know what a medical ethics committee is or exactly the role that you play in being an
Mhm.
interdisciplinary member of that, walk us through the process on how you take what you know and you translate
Mhm.
it into practice and help guide an interdisciplinary team and family through these very difficult situations.
That is an outstanding question. And I will start by saying ethics or um, committee members who are trained in ethics, not that clinicians can't pick it up along the way, but people who have been trained in ethics, at least for me, come at ethics committees understanding that our job is to assist when there are conflicts of value, right? When there are conflicts of value, either between the family and the care team, or members of the family, or whatever. But we're talking about values conflicts, not empirical conflicts, not unclear direction in terms of the medical treatment. We are here to talk about values. And that is sometimes very hard for people to get their heads around if they haven't studied theory. So, we're talking here about what people, and I use that broadly to encompass clinicians, family, friends, patient, everyone. Um, what is important? What would be laudable? What would be condemnable? What is why are you fighting this other decision that is being suggested by the other side? And um, I want to choose my words very carefully here. And here is why, very quickly. Uh, I When I was in Colorado, I did was part of a healthcare ethics class for University of Colorado medical students. It's Anschutz Medical. Um, and one student was highly resistant to this class. And he said, I don't understand why you are here. I don't understand why I have to be here. If there is a problem, I call legal. That's all. And you now, having practiced as a lawyer and having some training in healthcare ethics, understand that those are two different things. They often work hand in hand. But I always think that, no, that is an overstatement. I think that my job is to accurately represent the patient wishes and desires. Then I need to accurately represent the care team's position, and I need to accurately represent the family or friends' positions. And if we can triangulate those ideas, I'm not trying to oversimplify here, but then we can begin to say, here is a possible solution. Here is a possible solution. We are working within the confines of law and healthcare, um, but trying to simply articulate what positions are is valuable exercise. And for many families, this is the time where they say they feel heard, where someone is looking to them and saying, "What's important to you? Why are you making this decision? What do what's going on?" And many families, not all by any stretch, but many families find that a valuable experience as they work through their loved one's treatment.
Hmm.
Now, there are other things, right? Bigger things that we can talk about. We can talk about advanced directives. I would love to talk to you about that, those sorts of things. But in the committee situation, I try very hard to avoid formulaic thinking. And sometimes clinicians are trained that when you need uh, an expert opinion, you call the expert. And so sometimes they expect ethicists to come in and say, well, here's the right thing to do. You're done. Go, whatever. And that's not what we do because we are trying to accurately represent the values of all parties involved, and we are looking at ways to potentially resolve those conflicts.
Hmm.
That's what we're working on. How does it work? Lots of listening, lots of talking, and lots of argument in the committee. There's a reason they are committees and not just single individuals. Some hospitals have an ethicist. I am always made stronger when I am making decisions with other people because you get feedback from so many different sources. So I'm not sure where you want to go from there.
Yeah. So many questions. No, that was a great that gives me a window into your perspective. I was on our ethics committee in the ICU very briefly, but then I had
Yeah.
left my home hospital to travel. I had literally only attended a couple meetings as a
Mhm.
nurse representative. I feel like I now have a better understanding. I feel like the audience and just people have a better understanding of what is the role of an ethics committee and how does philosophy, something that we think is so abstract and inappropriately we deem as maybe not so useful in society,
Mhm, mhm.
are the most important things that we're talking about. We're talking about human beings and health and death and dying, and
Yeah.
I'm happy that we're getting back to humanities and back swinging the pendulum back to philosophy and humanities right now. That's super important. Where I wanted to go with that is just acknowledging your point, which is a really good point that sometimes family members just want to be heard. And that in itself, the
Right.
catharsis of creating time and
Yeah.
space to sit there with them and to empathetically and actively listen
Mhm.
that helps resolve some of the feelings that they are dealing with.
Yeah.
And that can solve a lot of the problems and the friction that I think we experience, as healthcare providers. I wanted to ask you too, in this triangulation that you kind of laid out, what competing values, what does it come down to in each of those points on the triangle from your perspective? Is it often the same competing values, or, what have you seen when you're actually weighing, the values of the care team versus the values of the patient
Yeah.
and the family?
So, it depends on the case. I think the easiest cases ethically are when you have a patient with an advance directive because their values are laid out. And you might be doing the work of interpreting what they've said because, as you know, legally, you cannot draft a document that covers every possibility. Um, but nonetheless, any advance directive is helpful. Um, Often, what I found, and again, I could be subject to my own bias from repeated exposure, but the care team often expressed moral distress at treating a patient aggressively that they did not believe would benefit from the treatment. And this is the important concept that I think many families and my students even miss, that clinicians need not offer non-beneficial treatment options, right? And if you have an actively dying person, there is no returning to baseline. There is no they're dying. You can sustain the body for a little bit, but not forever. And so when you have a care team saying this patient is actively dying, even intubation, whatever it is, isn't going to help, then that is an empirical fact that needs to be better communicated to the family. And I do really resist ethics committees or ethicists becoming some sort of counselor who can relay information that they don't want to hear. That's not what we do. But conveying information more accurately, possibly more humanely, more empathetically, as you have said, can go a long way. But I would say my first inclination is what do we think the patient would want and why? What kind of evidence do we have? And then what is the care team saying? What other options are there? Have they offered other options, etc.? And then why is the family resisting? And um, because of the fact that clinicians need not offer non-beneficial treatment, um, the family values often are not calculated or added into the equation at the same level, if that makes sense.
Yeah, that's interesting. I'm wondering to what extent, I'm thinking of like the Hippocratic Oath, right? That
Mhm.
physicians take and do no harm. I don't know how many of them truly internalize that and associate that with death. Like, do they think death is harm? You know what I mean? Like that is what I'm wondering. Or when we're talking about decisions and people not wanting to feel guilty,
Mhm.
I wonder if, the moral distress that I experienced as a nurse was very real, in those situations that you're talking about, especially in the ICU. But I also wonder, physicians carry a lot, right? And
Oh,
I
absolutely.
I wonder to what extent they don't necessarily wanna be the person or the voice who who's kind of like the death doctor who says, "Yeah, like, we
Yeah.
shouldn't do anything for your loved one." Nobody wants to be the person to say that to another human being, you
No.
know?
No. I think that's why they are taught the distance they are,
Mhm.
right?
Mhm.
In their training. But yeah, no one wants to be that person. And yet here we are.
Mhm.
Uh, so I think we need, again, to back up to an earlier point in medical education, there needs to be more than simply, um, you know, a 1 hour simulation of bedside manner. I remember being an assessor for some medical classes as they were doing their tutorial slash exam, and I just thought, "Holy cow, I would much rather you be a genuine human being and speak freely and possibly make mistakes and all of these things than this scripted, weird, awkward thing." But
Mhm. Mhm.
yeah,
I I resonate with that because I feel like there's a degree of you're supposed to remove yourself
absolutely. You're trained
somehow.
in that way. And
Truly, yeah.
there is survival skills
Mhm, mhm,
involved
absolutely.
in that, for
Oh, yeah.
sure.
Oh, yeah, that's my theory on healthcare is really I think physicians, clinicians, nurses, we're in survival mode, right? We're doing the best to survive a
Absolutely.
broken system while trying our best to care for other human beings, right? And that I think there's a degree of using metaphors, right? So we started referring to nurses and doctors as heroes and superheroes,
Yeah.
right?
Yes.
And
Absolutely.
the language matters because you start reinforcing and you put on this mask and this superhero outfit, right? And you
Mhm.
feel like you have to be this not cold, but like strong, right? Emotionally removed, very
Perfect
technical, right?
decision maker.
Mhm. But what I found throughout my experience and in observing, how families would respond to different conversations and to different intensivists, different ICU docs, depending on the week that it was, and grand rounds and how families would respond, the doctors who were authentic and would
Mhm.
show up human, very
Yeah.
human and vulnerable and honest and sitting down with family members and I hear you. I'm here to listen. What questions do you
Yeah.
have? Instead of coming in there with this, God complex or superhero mask and outfit that they've put on, to be strong and put on a strong face and, come in with their technical jargon and their calculations of, quality of life discussions, all these things. Families responded so much better. Patients responded so much better to
Yeah.
just authenticity and just being human. I think
Yeah.
definitely there's a place for that. There needs to be a place for that in medical education and nursing. I would say nursing we do get a little bit more training than physicians on how to establish what they call like a therapeutic milieu with
Mhm.
patients, right? So
Mhm.
we get a little bit more of that training, but I think there is a place for doctors to get more of that training. If I could just wrap up a little gift and poof, like give it to our healthcare
Yeah.
system, that is what I would give.
I agree, but they also need the time and the space to do
Mm.
that.
Mhm.
And
Mhm.
unfortunately, and this is an entirely different subject, a for-profit healthcare system does not prioritize the time physicians will spend with the family of a patient who is dying, um, because eventually the dying patient's going to count against their ratio in whatever way. And They simply they don't get paid for that. And in fact, the clinicians who respond the way that you are suggesting, and I agree completely, don't get rewarded for that. They don't get paid for it. They don't get promoted for it. And I think to make an even more radical suggestion would be that maybe, now we have palliative care specialists. Maybe we need um, death and dying specialists
Hmm.
who train in medical school and go on to work specifically so they can come into ICUs and oncology wards and these sorts of places and say, I am here to listen to your concerns and talk to you about what physically will happen. We know hospice nurses are very good at doing that, but that kind of training and to go back to our very first comments, pulling out the caregiving at the end of life away from medical treatment might go some space to correct some of it. I'm not going to be able to accomplish that, but it might be my wish if I could.
It doesn't have to be something big. I mean, even through just having this conversation and having
Yeah.
conversations with our family members and our loved ones. And that was a question I had for you is, you think about like the saying about like Thanksgiving, right? Don't bring up
Mhm.
politics, don't bring up, whatever, in these discussions with your family at Thanksgiving. How the heck do you bring up death and dying in casual conversation? How do we normalize death and
I'm
dying?
sure that I have a good answer for that. And it's funny you bring up Thanksgiving because I often give my healthcare ethics students an assignment, which is they have to, over Thanksgiving break, speak to one family member or friend about their end of life wishes. They really hate that assignment. They're like, I'm not bringing that up at Thanksgiving. Like, it doesn't have to be hard. So, one of the ways that I suggest people often begin is by talking about organ donation status, right?
Hmm.
Are you an organ donor? What organs do you want donated? Are you designated on your ID? Because currently in Ohio, there are organ procurement, organ OPOs, who are called when there are potential um, organ donations to be had. And some people appreciate that, and other people really don't. So it's a bit controversial, but are you an organ donor? What do you want me to know if you were in a car accident tomorrow? Should we donate your organs or not? What do you think? And you can share your own organ donation status. And I think organ donation is a more neutral
Hmm.
entree. And
Mhm.
I don't like having to maneuver around it. Like, I wish that we could just say, like, so, what do you guys think about what you want? Anybody watch that movie even? If there's a current movie or a show where everyone's watching and there's an end of life issue that comes up, that's a good one too. But organ
Mhm.
donation, I think, is a good practical way to start.
Mhm.
And you can then just start talking about, well, here's what I would want. And there's two basic kinds of advance directive. There's the informational, which is a list of items or rules that the patient wants followed, also known as a living will. The other one, which is more powerful, actually, is the power of attorney. So, if people want a particular person making their decisions on their behalf, they should name a power of attorney. This all has to be done legally, but it's not a hard process. And I think, simply talking about like, I've been thinking about what I want because I'm in this class and this is kind of what I'm thinking. Would you guys be okay in confirming that decision? So, for example, many of my students are going home to their parents and that family. And in Ohio, there is a decision maker hierarchy such that if anyone comes in incapacitated, they're going to find their family. And depending on their place in life, they will choose the appropriate person. If we're talking about adults, first is spouse. The second is, I think, um, parent. Third is adult child. And it goes through the list. And if you happen to be in a place in your life where you're like, yeah, my spouse would know exactly what I want and you're comfortable with that, okay, that's who they're going to anyway. But let's say that you are a college student who perhaps has been moving away from your parents ideologically, and you're now thinking like, I don't know that I want my parents making those decisions for me. Then you, college student, need to have a power of attorney that names someone specific who you trust. And that is more powerful than a list of directives because the power of attorney is a human being that clinicians can speak to and pose questions to. So, absolutely, if you do not think that your closest family members would approve of or support your end of life decisions, get a power of attorney. So important. And even if you don't want to do that, again, an informational advance directive is incredibly helpful. It at least gives signposts.
Mhm.
Inevitably, there will be some situation that is not covered by that, but we have directives. We can read the map
Mhm.
from those. But the power of attorney is the most powerful um, way to protect your decision making at the end of life. And then the next thing is you have to talk about death a lot.
Mhm.
You every time you see a movie, you need to say, this is what I would want or not want. Every time you see an ad for I there would be no ads, but if you see some sort of anti DUI poster, you should say, "Here's what I would want. Here's what I
Mhm.
don't want." He
Mhm.
That has to happen over and over and over because, you know, there is a likely not a likelihood, a small likelihood that you may have to go to court and defend your decision in court, and the court is going to say, "What evidence do you have?" And you need to be able to say, "We talked about this on this occasion, and that occasion, and that occasion." And I don't mean dates, but,
Mhm.
courts
Mhm.
demand more than simply, "That's
Mhm.
what he said."
It's so important to have those conversations, before you're in the ICU,
Mhm,
intubated,
mhm.
sedated. with your family
Yep,
at the bedside, right? And that was something that
absolutely.
was so shocking to me, how many people didn't have an advanced directive and were for the first time having this discussion when their family member is literally on life support. Like, this is the first time that they've
Mhm.
ever even explored that discussion, and it makes me wonder, I'm like, "Okay, is this like a process improvement issue? How can we?" Because we tied organ donation to driver's licenses, right? Is there
Uh-huh.
an easy, frictionless kind of way, right, that we can make this decision a little bit easier for people to make, or present them with this opportunity to even think about it a little bit earlier on and more
Yeah,
proactively in life, and not in a scary or judgy way.
yeah.
One thing that you said that I'm stewing on is ideology.
Mhm,
We're so polarized as a people right now in this day
mhm.
and age,
Yeah.
and we do not know how to have conversations where our beliefs and our
It's
values differ.
yeah,
We
exactly.
see different as a threat to our own values and existence.
You are right.
And okay, so death and dying are tied to people's belief systems and their values.
Mhm,
And sometimes they're tied to, we both had a religious, upbringing,
mhm,
recovering Catholics, right? So we have religious values. We were raised
mhm.
with religious values.
Yep,
And I think all too often people even take the invitation to have this type of a open, critical, candid conversation about, what do you think about death?
mhm,
And sometimes people will shut down before
mhm,
they even get started because they feel your default mode network, your brain is like, "Oh, I feel attacked." Your amygdala is like, "Oh, well,
mhm.
my beliefs are at stake here, right? Are they gonna attack my beliefs?"
Exactly. How you get the backfire effect and all of that.
Yeah, I don't
Um,
have you found a way to navigate these crucial conversations in a way that doesn't feel threatening to someone?
I would say that there is, uh, at least in theory, a way to do it. I'm not saying it works.
Mhm,
But for example, let's just say that there is an adult child having a conversation with a parent about end of life stuff. And the parent, shuts down because maybe the child is no longer practicing that religion. um, the child can say, "It's really important that I hear your position because I will honor what you want. This is about the dying person. Right? This is about the dying person." And trying to say, "This isn't about what I think. We can have that conversation next. um, this is about your belief and what you want. And I need to know what it is that you want in your own belief system." And I think that gets lost a lot. That people sometimes feel attacked when they're being asked about this stuff. And truly, these questions are to honor the patient's autonomy, honor the patient's faith, honor everything about that patient, and anything we can do to reiterate that. And truly, sometimes people just are like, "Oh, I thought you were going to tell me I was wrong." You get to die in the way that you want. Well, that's not true. We know that's not true, but, um, it would be ideal if you get to die in the way that you want, and I want to make sure that that happens for you. Um, Now, are there more complicated situations where that won't work? Of course, but it's a good way to start. For many people, it's that child and parent have grown apart r religiously. And Um, like simply saying it's not about me and my beliefs. It's about you.
Mhm.
We want to make sure that your voice is heard. And, this goes back again to the beginning. People fear the loss of autonomy.
Mhm.
We should be able to give that back at the end of their life. All of this strife is because we can't have that initial conversation about what people want.
Mhm.
And that seems to be easier to start than to clean up the mess after.
Mhm. Yeah, I agree
I
with
mean,
you there.
perhaps shouldn't call it a mess. But families and friends, they struggle. They
Mhm.
do.
Yeah, it can be very messy, but I like this idea of leading with empathy, leading with the idea of agency and autonomy and leading with, well, what would you want, right? Approaching your parents or grandparents with what is important to you and what would you want?
Yeah.
I want to make sure that I am honoring you and
Yeah.
your wishes, right? And then
Exactly.
almost ask for it back, right? Okay, well, I would appreciate, the
Yeah.
mutual respect of you honoring these are my wishes, right? And this is what I
Mhm.
would hope
Mhm.
to happen. And kind of fostering just a really empathetic conversation that
Uh-huh.
communicates mutual respect and
Mhm.
really acknowledges that okay, well, we are both like normalizing death, right? We are
Yeah.
both. I might be what 29, you might be 50, 60, 70, 80.
Mhm.
We are all approaching the same destiny.
We will all end up there.
Yeah.
Um,
Yeah.
so how can we best make it a motivating factor for the way
Mhm.
we live
Mhm.
and then not be terrified at
Mhm.
the end, right?
Mhm.
That, yes, of course. Loads of people will say, I'm not afraid of dying. I'm afraid of how it will hurt. Don't believe
Hmm.
it. Don't believe it. I think that's some denial. I don't understand how people can't be at fear is a common emotion, as we've
Mhm.
said. We are evolutionarily evolved to want stability.
Mhm. Mhm.
Death doesn't give that, but
No. Can I ask you, I'm wondering what your understanding of death and dying has helped you understand or appreciate about living.
sure.
Like what is, studying mortality and different schools of thought on death and dying and what happens and how people navigate that, I'm thinking of, the book Regrets of the Dying, right? The regrets
Mhm.
that people have about maybe not living their life the way that they wanted to, or living authentically, or not working as much as they did, or not letting
Mhm.
themselves be happy. So, in that vein, I'm just wondering what studying death and dying, how that has shaped your idea of living.
Yeah. Um, I can tell you that theoretically, it's different than what's in practice, but we live in the society we live in. I lean existentialist in my thinking. So Beauvoir, Sartre, Camus, classic French existentialists. Um, and I believe that, and I think this is a fair interpretation of Beauvoir, but the fact that you will die tends to, first of all, make people want to, like, store up their life or their, um, pleasure in life. two fundamental conditions, finitude, fallibility, and I do tend to lean existentialist.
Can you
Uh,
explain, just for the audience,
yeah,
briefly, that school of thought, what that means?
yeah. So I could, I will paraphrase Jean-Paul Sartre, who said, we are thrust into existence, um, and met with nothingness. And Camus, I think, expressed it better, which was, that we call into the universe asking what is the meaning of life. And it's not like the universe answers and says you can't know it. The universe simply doesn't answer because we are not a fundamental aspect of the universe. So, what this means for Camus and Sartre and Beauvoir and many other philosophers is that, look, no one asks to be born, but we are born. And so, once we become functioning adults, we choose how to live and we make a path for ourselves. And it's very easy, and this is the problem that I face. It's very easy to get sucked into I have to go to work because I need to have money, because I need to pay bills because of XYZ. And what we really need to be asking is how am I living a meaningful life? And there is no exterior answer for that. That is something that individual people build. And that is what I'm trying to do. We don't want to live because I'm getting acclaim or I published a book or I I don't even know, got a raise. That's not going to be meaningful to an individual unless they've deemed it meaningful. And so this to me is the challenge. Living a life where you choose meaningful activities. And admittedly, sometimes you don't know what's meaningful until you try it and it's not. That's fair. But the point is you you have to go out and do things. I personally do not believe that there is any kind of meaning to any life other than that is created. Now, I will add the caveat there are so many oppressed peoples who don't have that freedom. And I'm not talking about children. I'm not talking about folks with cognitive delay, right? I'm talking about adults, but we are the authors of our own meaning. And the fact that we die should help move us along. We know that we don't have forever here. And I understand some people believe that what comes after is Eden, something better. Many people don't. So, how do we live this life as meaningfully as we can? And
Hmm.
I don't have a good answer for that. There are too many very sad cases where people don't have that opportunity, and
Mhm.
I don't know what to say about that.
Mhm. I agree with your perspective. I had this observation myself, and I'm in a messy season of life where I'm figuring out, okay, what's meaningful to me? What is a meaningful life? Because
Mhm.
I think also often we are raised with expectations from family, society, who
Mhm.
tell us what a meaningful life is, right?
Yes.
And that might be their version of a meaningful life or society's version of what we have
Yep.
prioritized,
Mhm.
whether it be profit or output or productivity or whatever.
Yep.
It's interesting, I feel like millennials and Gen Z were kind of waking up to this idea. I know especially Gen Z, they're very purpose driven, right? We're
Mhm.
arriving at this thing that you told us was, like, the thing that we were supposed to do, right? And we're here and we're looking around like, this is
This
it?
is it?
This is what you
Yeah.
got?" Like,
This is
it's
all?
yeah,
Yeah.
and we're craving meaning right now, but I really resonate with your point about people who are oppressed to a degree and
Mm.
cannot even get so have you seen that video above the line or below the line? Do you know what video I'm
No.
talking about? Okay, I'll share
Mm-mm.
this with you, you will love this. Um, so many people unfortunately, I saw this at a leadership conference, in a workshop, but the way the presenter described it, after we watched this video is, unfortunately, so many people live below the line. In terms of they are motivated by fear and
Mhm.
guilt and anxiety and, the fear of uncertainty and fear of being
Obligations.
rejected, obligations, right? Expectations, and it's
Mhm.
so easy because I found myself in my legal career just last year, I found myself on this hamster wheel where I was just in survival mode every single day
Yeah, I know.
and it took one moment of stillness, right? For me, like I went to this sound therapy, sound bath class. It took 60 minutes of stillness. And I was like, oh,
Amazing.
I haven't had like that was me being able to like get above the line for the first time in
Yeah.
years, right? To see clearly, to have a lucid moment with myself, like, what am I doing? Am I living authentically? And here's the thing too about that is I was talking to my husband about this because he made this observation is he's like, it's such a privilege to be able to even sit here and pontificate and read all the books and oh well what will
Yeah.
make my life meaningful? How can I achieve that? And I think so many people, unfortunately, in our society, whether it's through, the values, the things we've placed value on, the way that we're raised, spend life below the line and we're maybe
Absolutely.
afraid of what
Yeah.
happens, afraid of the what if we go above the line.
Yeah.
But
Well, and
that's
often you
yeah,
have to
yeah.
break norms to
Mhm.
get above the line, and I don't even understand clearly what the line is, but I do understand the concept
Yeah, yeah.
that, and there are some people who simply can't, and that's
Mhm, mhm,
the
mhm,
evil of
mhm.
this society is that it's
Yeah.
designed to keep people below the line, you know?
Mhm, mhm.
Um,
Yeah, above the line, I will share was just ima an imaginative world, right? Imagine the possibilities of who you could be, of what life could be. Imagine psychological
mm,
safety. I was analogizing it in my head to like Maslow's hierarchy of needs, but they just simplify it to above the line or below the line, right? Like,
mhm,
do you even have your physiological, your emotional, your social
mhm,
needs met to feel safe, to feel like you can even
mhm,
ascend to a place of self actualization or figuring out who you
mhm,
are? Right?
mhm.
I don't think a lot of people have that, and I realize even though
Yeah,
I, like, on paper, like, had all the things, right? The career and the money and the whatever, like, I felt like I was living below the line, right?
I
Like
don't know that I am living above the line, to be perfectly honest. This is the job I have now, and this is what I do. Now, what I adore is the clinical ethics.
Mhm,
But yeah, this idea that we are on the hamster wheel. Um, I think that is far too reinforced, and I hate to go political here, but by a capitalist becoming more nationalist society, Like, we are trained that this is your one shot and you have to go all in or you're not worth anything, right? And God forbid you give up a paycheck to try something different. And yet, anyone who fully understands they're going to die should be doing exactly that, right? Should be like taking the risks. And
Mhm.
I don't mean unreflectively, I don't mean, beyond. I'm talking within, again, conscripted bounds, but it's, I think it's disheartening that we live in a society that encourages the hamster wheel and does not encourage passion, creativity, innovation, change. That's
Yes.
what we are about as humans,
Mhm. I will say
you know?
the hope and maybe the canary in the coal mine, Gen Z in the age of AI, right? And just us as a society swinging back to this place of humanities and talking about our human experience and recognizing having conversations like this, like what are we for? We are for
Yeah.
meaning, we are for each other, we are for connection, right? And I think in the age of AI, it's kind of exposing, oh, we haven't talked about these
Yeah.
things, right? Maybe the ancient philosophers
Yeah.
were talking about these things, but we were like, "Oh, that's not practical. Let's put a pin in that. Let's start building, let's start producing."
Exactly.
And that's fine and dandy. That got us somewhere, right? But now we're like, "Oh, do we need to evolve? Should we change something? Should we try something new maybe?"
You know,
So I'm hopeful.
as you've mentioned, like, this movement of brain capital,
Mm,
huge,
huge.
and,
Mhm.
why? Because it's emphasizing the humanistic elements, which is taught in humanities courses. But if
Mhm.
anyone's going to actually embrace their humanistic element, it includes the fact that you will mess up a lot and die in the end. So, what are you going to do to be happy and motivated in the meantime? And I personally think about, like, what am I leaving, right?
Mm.
I, I don't have children, won't have children. So my thought is always like, how will I be remembered? And that motivates me. But
I like that
I,
idea of legacy and thinking of the seeds that you plant, right, for the next
yeah,
generation,
exactly. You
and
never know.
I'll share, you left your mark on me when I was this little undergrad, right, like 18-year-old, 19, whatever, sitting in your my first course with you, right, intro to ethics, and you posed some of these questions, and then you said, "Well, what do you think?" Asking the whole classroom, and
Mhm.
hands shot up. And I had this moment where my mind was just cracked open because I had never been asked, "What do you think?" about anything, right? And the questions that you posed, I think that was like my
Really?
first exposure. Yeah, that was my first exposure to critical thinking. And
You've never been asked what you thought before.
no, I was raised in a household, we talk about like being recovering Catholics or whatever. I just was
Yeah,
raised in
yeah,
a household that's
yeah.
more children are to be seen and not heard, not really having
Yeah,
like open discussions. What's on your
mhm,
mind, right? Nothing like that. And even in high school, right? I started in public school, I ended up in a Catholic high school. But no, that was not, it was just, I think this speaks to public education today, K through 12. You
mhm,
are consuming and you are memorizing and you are spitting it back out on a standardized
mhm,
test,
mhm.
and we're not taught to truly think critically. I don't think I became a critical thinker until I started taking philosophy and ethics courses, and then until I became a nurse, and then until I became an attorney. I didn't know that until I was
Yeah,
literally like 19. So That would be a good, good little, if we could start,
That's another little interview, which
that is a
is the status
whole,
of
yes.
higher ed.
Yes. I want to close by asking you, so I ask every guest this question. Can you think of someone in your life who has left their mark on you, has impacted you, said something to you, done something for you? You don't have to say their name, but think of that person and finish the line from Wicked, the musical. Because I knew you. The line is, because I knew you, I have been changed for good. So if you can finish the line, because I knew you, in any way you'd like to, thinking about that person.
Would you like me to name the person
You can.
or not? And this isn't meant to be gratuitous, but because I knew you, Tatiana, I am motivated to rethink what is important to me and rethink how to achieve it and what change to make in the world. And please keep going. You have you have described your position as messy. It is not messy. It is very organized, well researched, planned out. You keep going because I have been motivated by you. So thank you for that.
Thank you.
Thank
I
you
don't know.
for being my student.
I don't even know what to say to that. I'm speechless right now. Thank you. Um,
You're welcome,
wow.
but it's true. Like, and I could generalize to say students in general, but you in particular have launched in the way that we hope philosophy students launch, which is you're thinking, you're changing your world, you are planning how to affect change in the world. You're there. Thank you for
Thank
that.
you. Thank you. And I to bring it full circle, let's acknowledge that in what I just shared about you breaking my mind open, right? I don't think I would be who I am today but for you and your impact in my life. So thank you for being
Thank
out
you.
there doing the work, being a philosophy professor, being a medical ethicist, and leaving your mark on the world. I think you're
Thank
planting
you.
the seeds for the next generation. Yeah. Yeah.
Well, we have some interesting work to
Oh
get
yeah.
through.
Oh
We both,
yeah. Oh yeah. Well, thank you so much for being
yeah,
being on Lucid Commons, and thank you for the gift of this conversation.
yeah. Thank you for having me.
Until next time.